Good afternoon, everybody. Next, we go into a situation where after trabeculectomy, we have problems. There is always ways to retrieve it. We're going to such situations. And first, we'll have Dr. Andrew Braganza. He's professor at CMC Vellore. He is one of my favorite teachers and a very practical glaucoma specialist. Go ahead, Andrew. Well, let's talk about shallow AC with low intraocular pressure in a post-trabeculectomy setting.
Okay, good morning, everybody, or should I say good afternoon. First of all, just to let you know, no financial interest in anything that I'm saying.
Sir, just a second. Could you have some quiet in the hall, please?
Yeah. So when we evaluate a patient after surgery, we do a routine post-operative evaluation, which I've actually listed here because it's not common for everybody to do all these things, but we try to do it. So you have to do a proper slit lamp examination. Torchlight will not do. You need to do a Seidl's test. You need to check pressure with applanation. And then, of course, you assess the bleb. And if necessary, you can do, even on the first post-op day, you can do a gentle gonioscopy if you need to have some information about what's happening inside. I'll go over a clinical approach to a shallow anterior chamber. And basically, one would look to see the IOP next. And if it's a low IOP, you would suspect overfiltration or a leak. And with a normal or high IOP, you would suspect aqueous misdirection or underfiltration. So here's a sort of flow chart. You have the shallow AC with low IOP. You look at the bleb configuration. You have a flat bleb with or without a leak, and you follow this left-hand side flow. And you have a formed bleb. You have to assume overfiltration. Now we have a flat bleb with a leak, let's say. We need to consider what are the factors which actually control the flow through the trab. The most important is the amount of scleral overlap. When you have created your superficial scleral flap, how much does it overlap the ostium that you have created under the flap? Next would be the tightness and the number of sutures, because that affects what resistance the aqueous has to flow against. And then the thickness of the flap, again that affects the resistance. The actual size of the internal ostium, apart from creating more than the little minimum that you need, doesn't really matter very much. We all excise more than an adequate ostium. Other factors causing hypotony would be the leaks from the conjunctiva, and usually it's a conjunctival edge leak, or it may be from somewhere else on the conjunctiva. If you have undersecretion of the ciliary body, that's ciliary shock, there may be buttonholes, there may be choroidal effusions which may be spontaneous or related to some other pathology. And rare causes would be foreign bodies within the, in the operated site, like a cotton fiber or something, acting as a wick to draw out the aqueous. The careful slit lamp examination will help you. So you need to first of all look and see, is there a bleb present? If there's a bleb present, it's unlikely that you have a very significant conjunctival leak. You do a Seidl's test to rule out the leakage. You look at the edges of the scleral flap, which you can usually see through the conjunctiva, and see whether any edge is lifted up or is showing a gap or a gape, and you look for loose and broken sutures. If necessary, you look at the internal ostium, as I said before. And you must always do a dilated pupil indirect ophthalmoscopy, looking for those peripheral choroidals. Now, all fornix-based flaps will leak on massage postoperatively. And when you have a spontaneous edge leak, as is being shown here in the video, you can try and address it with a pad and bandage or a contact lens or something like that. But conjunctival resuturing is usually indicated and can even be done under topical. This is a conjunctival edge leak which has been repaired under topical. And once that's done, you check through a paracentesis to make sure it's not continuing to leak. Now, when you have early overfiltration, there's no conjunctival leak, but there's just too much fluid flowing from under this scleral flap. You need to kind of induce that flow to be a little less, and you can do that by increasing the resistance to the flow. So you can use a torpedo bandage, the so-called pledget of cotton wool, which is placed over the eyelid and presses on the site of the trab. You can use a Simmons shell, which is a device which is shown here, which has a platform which presses over the site of the trab, and you try and compress that. One small clue that I found that is clinically useful is when you have a shallow or almost flat AC like this, if you try and support the bleb area with your thumb through the eyelid and you find that your AC is forming up, you're likely to get some results from your torpedo bandage shell or any other means where you can compress the site of drainage. If you have to intervene, your intervention would take the form of going and trying and revising your trab, and you need to know what's the appropriate timing. If choroidal effusions are already formed and have been there for more than a day or two, it's unlikely you're going to be able to reverse anything without actually draining those effusions. Conservative management will usually not work. You have to intervene surgically if the pupillary collarette is touching the cornea. The choroidal drainage is shown here, where it's a fairly simple procedure. You do need to have, you can't do it under topical, you do need to have a full peribulbar or retrobulbar block. It's important to realize, you can see a lot of fluid flowing out now, that you need to reform the chamber not with air, but with balancol, with a liquid, which is retained there without flowing out. Air will be retained even against pressure and upthrust, whereas a liquid will not be. So here you see that the chamber has been reformed and it's staying formed. This step is important where you try to cauterize the edges of your drainage site so that it stays open post-operatively. It needs to continue to drain in the first few days post-op, and you don't need to worry that it's going to stay permanently open. The sclera heals very fast. Probably in a week or two, it would have closed off. I have had occasion to go back and look at a choroidal drainage site 2 weeks later, and I found that I couldn't even find where the incision had been made. So other surgical interventions would be to just reform with an air bubble or use the Simmons shell, as I mentioned before. But if you have excessive overfiltration, you have to re-explore, and generally the re-exploration would lead on to putting a scleral patch graft. You can try and re-suture, place additional sutures, but usually the situation would be that the overlying sclera, the scleral flap, is now a little too thin and ragged for your sutures to hold well. So you need to cover it up. This is just an outline of what you would do. The indication for intervention and a scleral patch graft is if you have a high chance of infection, or if you have hypotony maculopathy or chronic corneal edema, anything affecting visual acuity. You can try autologous blood injection, you can try laser scarring of the cornea, and several things. Autologous blood injection is successful in about 50% of the time, but it's such an easy procedure, and here you can see I've shown a few slides, that it's worthwhile trying. It's almost non-interventional. Compression sutures can be tried, and they are very effective, but my personal favorite is to do a scleral patch graft. You use donor sclera and you suture the graft to cover the entire original scleral dissection, And the posterior edge is usually left unsutured so that it continues to drain in that direction. And surprisingly, it works and the glaucoma remains controlled in most of the patients. So I've just got a series of photographs to show you the steps of, you can see the size of the graft, it's fairly large. You must cover the entire area of a scleral dissection. So you suture it down, then you trim and thin the graft, and finally you do put a mattress suture near the limbus, and finally you close the conjunctiva. So in summary, you need to do a careful clinical examination and check the IOP post-operatively. You need to do a Siedel's test, if necessary a gonioscopy, and then you use whatever measures are necessary to address the root of the problem once you've diagnosed what the problem is. Thank you.
Thank you to Dr. Andrew. We will take the questions at the end of the session when we have time. So there is a slight change in the order of speakers. So now, when you have a bleb that is failing, in its early stage, can we salvage this bleb? To talk about this, I invite Dr. Thomas George, who is a consultant in glaucoma at the Chaitanya Hospital in Trivandrum.
Thank you, Kiran. Bleb essentially is reservoir subconjunctivally for the aqueous draining out of the fistula we create during filtering surgery. The fistula should give us adequate resistance to maintain the IOP and keep the shape of the globe and the structures in place, but also allow for a flow to keep the intraocular pressure low enough. Tissues tend to heal up. So if the space is not maintained in the healing period, that's the immediate post-op, it will heal on to the episclera. Hence, a leak itself would cause the bleb to eventually fail. So if you've got a bleb leak, like Dr. Andrew has already shown you, near the limbus, a large diameter contact lens may help. And if it's not resolving in a couple of weeks, you need to resuture. And a buttonhole in the conjunctiva definitely needs to be resutured. And if the leak is close to the limbus, we would prefer to mobilize it to the limbus and suture it onto the limbus. If there's no bleb in the immediate post-op and there's no leak, we would go for a massage. We'd keep the bleb going with massage, either finger massage from below or right above the flap itself. And we would hold it with this conservative measure still about 2 weeks, because we want some amount of healing before we tamper with the sutures and increase the flow through the fistula. That is, to release the releasable sutures or do a laser suture lysis, wait at least 2 weeks. In the meantime, we can use more of topical steroids and try to reduce the inflammation to slow down the scarring process. And if even after suture lysis or releases, the bleb is not forming and the IOP is not controlled, we need to plan on needling. Needling is for ideally a failing filter, though it will work for the failed filters if done much later also, but it works best for a failing filter. Timing should be at least 3 weeks post-op and can be up to 3 months to call it a failing filter in the sense that it's still not fully healed up. The procedure is to create a long subconjunctival tract and to do sweeping movements to release subconjunctival fibrosis. If required, we can go under the scleral flap and release the subscleral fibrosis also. You will see the bleb form. It's already starting to form in this video when the subconjunctival fibrosis is being released, and I'm going subscleral to make it flow a little more. And once you've got a good bleb, you turn the needle so that you're far away from the ostium. You don't want the mitomycin or 5-FU, which is more acidic, to flow into the anterior chamber. You stay far away and inject very slowly, hoping that the pH in the AC is not disturbed and the endothelium is not compromised. Mitomycin 0.2 or 0.4, 0.1 ml, or 5-FU 0.1 ml of the preparation that we get commercially, that's 50 mg per ml, can be used as the antimitotic during this process. Ring of steel, this is a concept that everybody has been talking about. You have an area which is exposed with mitomycin with adequate concentration to kill off the dividing fibroblasts. Those area, all the fibroblasts are gone. But there is an area beyond that where the diffuse mitomycin has got too little concentration to kill them off straight off. And these are going to be dying cells over the next 1 year. For 1 year, you're going to have tissue breakdown products in that area, and this would incite inflammation. Then this would incite fibrosis from fibroblasts, which is outside of this area, which are fully viable. And so you land up with a vascular bleb like what is shown on top. That one, where it has been walled off so that it can't flow any posteriorly, but we would prefer to have a bleb like what is here, which is a big area and petering off into the periphery. This is ubium, that's a scar tissue there that is stopping the flow. You would prefer to have something petering off like this and going into the periphery. And when that happens, your backward flow is gone, it dissects into the cornea, it can overhang on the cornea. All these are going to cause dysesthesia and visual issues, but also the IOP will also start to go up because the resistance is high. So a ring of steel also can be helped with needling because you can cut that ring of steel scar with the needle and give the antimitotic. If there's no bleb in the older trap and the ostium is open, consider that there is a scleral flap fibrosis. To look for the ostium, of course, you need gonioscopy. That's a skill any glaucoma specialist cannot avoid. You can needle from outside, like we showed, if you can see or find the edges of the scleral flap, which may be difficult in an older trap, but consider internal re-exploration or even bleb revision. For internal re-exploration, of course, a gonioscopy is a must because you have to be absolutely sure of where the ostium is. You do a paracentesis, fill the AC with OVD and use a blunt instrument. Here I use a regular iris spatula, go through it. You need quite a bit of force, and once you see it subconjunctivally, you know that the bleb is going to form and bleb forms, and you need to supplement this with the antimitotic as well. If required, once a bleb is formed, it's easier to do a needling to supplement this bleb that is formed. In short, leaks have to be dealt with in the immediate post-op to keep the bleb formed. Massage the bleb up in the early days and wait at least 2 weeks before we do a suture lysis or a release of a suture. Once fibrosis is obvious, go for needling of the bleb, and if there's a subflap fibrosis, we can consider internal re-exploration also. And right through, on gonioscopy, the ostium is blocked. We need to go in and deal with whatever tissue is blocking the ostium. Thank you.
Thank you, Dr. Thomas. Now, we had already discussed the shallow anterior chamber with low IOP. Dr. Andrew had discussed this. We will look at the other end of the spectrum. You have a shallow anterior chamber postoperatively with a high IOP. Dr. Sai Kumar, a prolific surgeon from Giridhar Eye Institute, he will be talking to us about the common causes and management protocols.
Thank you, TG, for having me in this course. And thank my colleague Dr. Manju Anup for helping me in this presentation. In fact, Manju does more of glaucoma work in my institute than I do now. So we all know that glaucoma filtering surgery is one surgery where you don't want the wound to completely heal. You want it to heal only partially. And we all know that we have 4 sets of complications that you can have in the post-operative period. 2 are due to flat anterior chamber, 2 are with deep anterior chamber, and of course either you have a low IOP or a high IOP. So these are the 4 sets of complications that one can encounter in the post-operative period in trabeculectomy. And I am going to discuss about the flat anterior chamber or a shallow anterior chamber with an elevated intraocular pressure. And basically we are looking at 3 entities here. The first one is a pupillary block, the second one is a delayed suprachoroidal hemorrhage, and the third one is the malignant glaucoma or the aqueous misdirection syndrome. The pupillary block, I think, or at least in my practice, should come in as the first diagnosis whenever you have a shallow anterior chamber with a raised intraocular pressure. So it is sedal negative, you can see the iris bombay. The AC is shallow peripherally, but centrally it is reasonably well formed. The intraocular pressure is elevated. Sometimes it can be borderline elevated or maybe slightly on the normal side, but with a flat chamber. You see a PI which is not patent. So normally you look at the area, when we do a surgical PI, we usually check whether it is patent on the table itself with the flow of aqueous at the end of surgery. But if it is not patent, it is one of the causes. Of course, you can have an air bubble which can cause a temporary pupillary block. For a very shallow chamber, if you have put in some viscoelastic, that can cause. If it is a complicated surgery or a surgery combined with cataract and you have some vitreous in the anterior chamber, that can cause a block. So whatever is the cause, the treatment to relieve the pupillary block is a laser iridotomy. So you do a laser iridotomy where there is an iris bombay and you puncture the iris, you let out the fluid and the block is immediately relieved. One entity which I do come across in my hospital quite regularly, not related to trabeculectomy at all, is a similar picture following vitreoretinal surgery. Maybe a week, 10 days, 2 weeks into VR surgery, the patient comes suddenly with low reduced vision, pain, and you examine the eye and you find that there is a lot of inflammation, the iris is stuck to the intraocular lens and you have this iris bombay. So for that also we have to do a laser iridotomy, something similar to this. Late suprachoroidal hemorrhage is not at all common. I'm not, this is what the literature says, but we haven't seen that many number of cases in clinical practice at least. And the risk factors obviously are uncontrolled hypertension, very elderly people, myopes, when the intraocular pressure is very high and previously vitrectomized eyes. And there is abrupt onset of nausea, severe pain, you have an inflamed eye with lot of with a loss of red reflex, very high intraocular pressure, and posterior segment evaluation, if you can see the fundus, you can see the choroidals, otherwise in a B scan you can see the choroidals. Small hemorrhages usually spontaneously resolve with topical steroids, maybe you may require some systemic steroids and the anti-glaucoma medications. The large hemorrhage usually requires drainage once the liquefaction has occurred, which is about 2 to 3 weeks. Aqueous misdirection or malignant glaucoma is actually a diagnosis of exclusion. Once you have made sure it is not a pupillary block or a suprachoroidal hemorrhage, it's more common in hyperopes. You have a shallow anterior chamber both in the center as well as in the periphery. The IOP can range from normal to very high in the presence of a patent peripheral iridotomy. So you know that there is some collection behind the posterior capsule which is pushing the entire lens iris diaphragm forward and causing this malignant glaucoma. So the aqueous misdirection is definitely one of the causes, and the anterior rotation of the ciliary body. These are the two factors which can lead on to the malignant glaucoma, and these are the UBM and ASOCT pictures which confirm the diagnosis. So the aim of treatment in malignant glaucoma is to deepen the anterior chamber to control the IOP, and to deepen the anterior chamber you have to have a few things to occur. One is a cycloplegia, which causes tightening of the zonules, the lens turns a bit backward. The aqueous suppressants and hyperosmotics are more important in these situations. Mild ones may help resolve with these medications. Cycloplegics are extremely important because that prevents the anterior rotation of the ciliary body and helps in treating the aqueous misdirection. So initially you probably do a peripheral iridotomy and check whether the PI is patent to exclude a pupillary block. You can do in an aphakic or a pseudophakic eye, you can do a YAG capsulotomy with an anterior hyaloidectomy. Hyaloidotomy preferably to be done in the periphery and not in the center. And in eyes with very poor vision, probably you can think of a diode laser photocoagulation. This is a video given by TG. So this is his technique, where you do a Chandler's technique, which is the 3-step procedure. First you check for the pupillary block and make sure it is patent, and then you do a posterior sclerotomy to look for a mild choroidal, and if both are not there, then just go into the vitreous cavity and let out some fluid. You need not very actively aspirate the fluid because our VR colleagues are not very fond of that. They feel that there is a lot of traction on the vitreous and the peripheral base of the retina, but you can just let out some fluid, and by doing that itself you can find that suddenly the anterior chamber is better, the eye gets softer, you can reform the anterior chamber. This is something which I intraoperatively, again not directly related to trabeculectomy, this is something which I use once in a while in the intraoperative rocky hard eye syndrome during cataract surgery. When you feel that halfway through the surgery you feel that the chamber is totally shallow, eyeball is very tight, so you can just go in with an MVR, release some fluid without actively aspirating the fluid, and that relieves the pressure and helps you continue with surgery. So in filtering surgeries, post-operative management, as we all know, can be much more challenging than the actual surgical procedure itself, and appropriate post-operative management, like all the talks that are we are hearing today, helps us in getting a good outcome. Thank you very much.
Thank you, Sai. That was an excellent talk and very clear and crisp. Thank you. Next, we have Dr. Kiran Gopalakrishnan. He is also a reputed glaucoma specialist from Precise Trivandrum, and he will be telling us what to do, which is better with a lead-feeding bleb, tube, or trap. Go ahead, Kiran.
So, in a late fail bleb, actually there are better options than either repeat tube or trap. We can do other procedures also, but for the purpose of this discussion, we will look at either of these two procedures. So, irrespective of the cause of failure of blebs, all of them have one common feature, and that is fibrosis. So, even if you go back early in 1983, where we could look at the histological samples of functioning blebs and failed blebs, you see the functional blebs are characterized by the presence of microcystic spaces, and the failed blebs are characterized by the presence of large numbers of fibroblasts. So we have tried numerous agents to combat this fibrosis and increase the success rate of traps, and we have succeeded to some extent with the use of mitomycin and 5-fluorouracil, but irrespective of the use of mitomycin, a significant percentage of blebs fail in the long term. Depending on the time frame and the studies you look at it, the failure rate is about 50% at about 10 years. And if you look at some really long-term studies at 14 and 15 years, it will show failure rates even as high as 75%. So in your practice, you will definitely face failed blebs. So should we now go in for a repeat trab or tube? Whenever we evaluate these procedures, we evaluate them broadly in two baskets. One is in success or failure rates, and other is in terms of complications. But this is a very broad basket. Within the success rates, you will also find variations in complete versus qualified success. And something we don't usually give a lot of importance to is the morbidity associated with each of these two procedures. Because by the time you are dealing with a failed trap, morbidity is the last thing you think about. Now with complications, you not only want to consider early and late complications, but also complications which are minor versus more serious ones that can really affect the patient's vision. Now, if you only relied on the data of the TVT, which is the level 1 high quality evidence we had addressing the same question of whether we should do a repeat trap or a tube in cases of failed traps, it's an absolute slam dunk decision in favor of tubes, because not only were the success rates higher for tubes at 5 years, the early postoperative complications were higher in the trap group. But we also need to keep in mind that the complication was dominated by two things: wound leaks, which is eminently preventable through a watertight conjunctival closure mechanism, and hyphema, which is very much self-limiting. Now, The late postoperative complications were similar between the two procedures, and the serious complications were also similar, though there was a difference in the kind of complications you had between the two groups, with traps having more hypotony related complications and the tubes having more implant related complications. Now TVT is level 1 high quality evidence, but the TVT patients had a baseline IOP of 25 plus or minus 5. We will have patients with much higher ranges of IOP in our practice. 81% of the patients had primary open angle glaucoma. Would it be different between the two procedures if you had a higher percentage of angle closure glaucomas as we have? All the patients in TVT had a barbell implantation and 0.4 milligram per ml of mitomycin C. We will use a combination of both valved and non-valved devices and generally use lower concentrations of mitomycin C. And of course, TVT's data from the most accomplished surgeons in the real world. Patients will have to deal with surgeons like me as well. So let's look at some real world data. So this is a study from the US Medicare beneficiaries. They have this wonderful data and they classified these patients, and we'll omit the first group of primary trap because it's not relevant to our discussion here. We'll compare the trabeculectomy with scarring and the tubes. So here in the real world, the tube patients had more of adverse outcomes compared to repeat traps. So even in, not only in the less severe adverse outcomes, even in the more severe adverse outcomes, those the tubes had greater incidences of endophthalmitis, corneal edema, and more incidences of blindness and low vision, though they had lower reoperation rate. So the real world data is a little different from the RCTs. Another real world data is from the IRIS, the Intelligent Research Insight, which is a registry that is being compiled since a decade now by the American Academy in collaboration with the other national ophthalmic societies of the world. And they have a TVT cohort. And again, if you compare the results, the advantage that tubes had over traps in the original RCT, in the TVT RCT, is not replicated here. Both had similar outcomes. But in fact, the complete success rate was higher in the TVT cohort of the IRIS registry at about 53% compared with 34% at complete success rates. What about morbidity? What about the recovery of visual acuity, the recovery of pain, and all these things that make a difference to the patient? So again, this is a study that looked at this very same question. We are omitting the cataract patients because they have a huge improvement in everything. So with visual acuity, again, you had a slower acuity recovery with tube surgery compared to trap surgery. If you look at the pain scores, again, tube patients had a slower pain recovery compared to traps. Patients generally had to take more time to return to work, to come back to drive, and all these with respect to tubes compared to traps, which makes sense because generally tube surgery is involved with a much greater amount of dissection. So if you look at both real world data and the RCT together, tubes and retraps are not hugely different. It does not mean that tubes have a huge advantage over retraps. But what are the factors that might help us choose one over the other? In general, when you have to do a retrap, greater the fibrotic potential of the eye, prefer tubes. So one way of looking at it is the time to failure. Say you have a trap that has failed over 6 months to 1 year compared to a trap that has failed over 10 to 15 years. Obviously, they will behave differently in a retrap. So the faster the failure of your primary traps, you can prefer tubes. And also look at what was the original indication for the trap. The original trap was done for a uveitic eye or an NVG, or if an eye had had multiple surgeries, you prefer tubes. So look at this example. This is a previous trap eye, but you also see the silicon oil bubbles there, the pseudophakic eye. This is a traumatic eye which has undergone multiple surgeries, and with the level of inflammation, a repeat trap is definitely going to fail in this patient, and subsequently this patient did well with a tube surgery. Generally, if you have a lower baseline IOP and you want the patients to be brought down to a very low target IOP, you prefer traps. This is from the TVT IRIS data. You found that the tubes perform poorer in lower baseline IOPs. When the IOP is greater than 26 baseline, they tend to perform much better. Even the original TVT study showed something similar. When the baseline IOP was high at more than 25, you can see the huge difference between the tube and the trap, with tube being much more successful. But with IOPs less than 21 or between 21 to 25, the difference between the tubes and traps is kind of diminished. Whenever you have a greater risk of corneal decompensation, you prefer traps. It doesn't mean that a patient needs to have a corneal pathology, you have a phakic patient or a an angle closure glaucoma, very difficult to put in a tube in the sulcus in phakic patients. In such patients, you can consider TRAB as an option because we know very well, even from the TVT data, that corneal edema following either of these two procedures is much bigger with the tube surgery. If you look at it in another way, if you look at the percentage of patients who underwent an endothelial transplant, again you can see that TRAB is nowhere in the picture. It's the tubes that causes maximum endothelial damage. So eventually, it's not just the TVT data where tubes, when you have a failed TRAB, immediately jump in for a tube. It's not that. The choice between either of these procedures is certainly more nuanced and multifactorial and not a slam dunk win for tubes. Thank you.
Thank you, Kiran. As usual, well researched and well presented. Now I call upon Dr. Manoj to tell us what to do when we glaucoma specialists really don't know what to do, and that is in a phlebitis, post-TRAB infection. Manoj is a VR surgeon with us in Chaitanya, Trivandrum. I don't think anybody in Kerala is left without knowing about him. Go ahead, Manoj, please.
Thank you, Dr. Thomas, for giving me this opportunity. I'm a little misfit here in this glaucoma IC, but always nice to help the department because they always do us a lot of favor managing all our glaucomas. So my talk will be on blood-related infection. And blood-related infection is a late complication of trabeculectomy. And broadly, this can be classified as phlebitis and blood-related endophthalmitis. If you look into the literature, the incidence of blood-related infection is in the range of 0.4 to 6.9%. The collaborative blood-related infection study reported a 5-year cumulative incidence of around 2%. There has been a decrease in the incidence of blood-related infection, and this is mostly because of the refinement in the surgical techniques. Now, some people have classified blood-related infection as early and late. The cutoff period is somewhere between 4 to 6 weeks. Investigators have proposed a classification system for blood-related infection. Stage 1 is when there is typical phlebitis. The bleb involvement is apparent with the erythema around the bleb and a milky white appearance of the bleb with loss of clarity. Stage 2 is when there is anterior segment involvement in the form of hypopyon. And stage 3 is when there is cellular infiltration of the vitreous. The Japanese Glaucoma Society further classified stage 3 into 3A and 3B. 3A when there is mild vitreous involvement and 3B when there is marked vitreous involvement. And this is based on both clinical and ultrasonographic findings. So the most important thing that we have to remember is that we need to suspect this problem. Pick this up quite early because the symptoms are very, very subtle. Patients may have just a redness, mild redness, discharge, and foreign body sensation. The bleb appearance gives off the clinical picture. You have a nice whitish looking bleb with a lot of congestion around. The transparency of the bleb is lost. Phlebitis often is the first form of the disease, and this actually progresses to blood-related endophthalmitis very soon. Defective vision and floaters will actually follow later on. If you look at the risk factors of blood-related infection, there's a whole big list, right from systemic factors to use of topical steroids, antibiotics, and adnexal problems, and also various blood-related issues. Blood leaks seems to be the most important predisposing factor. This analysis from the glaucoma clinic at Arvind Tirunelveli, they found that when it's an early phlebitis, it was commonly associated with coexistent lid pathologies. And when it was a late onset phlebitis, it is mostly related to blood leaks. The collaborative blood-related infection study also reported that the incidence of blood-related infection was more when there are blood leaks as compared to those eyes where the blood leaks were not documented. Also, people have looked at whether there's a difference between fornix and limbal-based flaps. The collaborative blood-related infection study did not find a difference. Augmented traps definitely carry an increased risk. Both mitomycin C as well as 5-fluorouracil have been implicated, though there's no difference between the two data. There's some studies which have shown that mitomycin may be slightly having a higher risk. Blood manipulation, suture lysis, blood needling, autologous blood injection, compression sutures, blood revision, all these are known risk factors for blood-related infection. Some people have argued that these manipulations happen months before the actual onset of endophthalmitis, and it may not be related, but the association seems to be very strong. Again, is combined surgery a risk factor for blood-related infection? The collaborative study did not find any difference between trabeculectomy and combined surgeries. Tube versus trap data, I think Dr. Kiran showed partly this data. There's no major difference between the tube and the trap data. However, there's a recent review which commented that following tube shunt surgery, the reported onset of endophthalmitis appeared a little earlier when compared to those following trabeculectomy. Now, if you look at the spectrum of organism, this is from the West. This data. Streptococcus seems to be the most common organism implicated. Following that is Staphylococcus, Enterococcus, and Klebsiella. The spectrum seems to be a little variable. It depends on the stage of the disease. The spectrum changes, and again, in early blood-related infection, it is mostly Staphylococcus which is implicated, and in late ones, it could be Streptococcus or gram-negative organisms. Also, problems like if you have a nasolacrimal duct obstruction, the commonest organism could be pneumococcus. So, other associated pathologies also can help us identify what the possible organism. One needs to remember that the spectrum is very different from the cataract post-operative endophthalmitis. Culture negativity, it's in the range of 21 to 86% in the reported literature. Indian data, it is even more higher. So one needs to send the samples to a very dedicated ocular microbiology lab to have a better pickup. PCR is a useful technique because the sensitivity definitely is better with PCR. We should also be aware that the antibiotic sensitivity spectrum is changing in India because of the prolific use of fluoroquinolones. In fact, the glaucoma study from Tirunelveli showed that most of these organisms were sensitive to the older chloramphenicals as compared to the newer fluoroquinolones. This is a patient, 55-year-old lady who underwent mitomycin trap for primary open-angle glaucoma and had a good initial post-operative outcome. And 2 months after, the patient came with a visual acuity of hand movements. As you can see, the anterior chamber, there is hypopyon at initial presentation. We did a B scan, and ultrasound did not show any evidence of any vitreous exudates. So we started treating this as a typical case of phlebitis. But on day 3, the ultrasound started showing some changes. You see vitreous exudates appearing, and also the RC is kind of thickening. And at this point, we decided the patient has moved from stage 1 to stage 2, and we gave an intravitreal. And this is stage, on day 5, again, you see there is still increase in exudates and increased thickening, and patient received yet another intravitreal injection. Always one needs to take conjunctival culture in these patients. As I said before, sometimes these phlebitis are commonly associated with lid adnexial pathologies. So in this case here, it grew Staphylococcus. The vitreous tap was sterile in both the occasions. PCR was negative for bacteria and fungus. Fortunately for us, the patient did well after those 2 injections. And these are pictures on the 20th day. The patient's visual acuity regained to 6.9. The intraocular pressure was 9 millimeters of mercury. So in a nutshell, the management depends on the stage of the disease. In stage 1, topical and periocular antibiotics are good enough. Typically, we use fortified vancomycin and ceftazidime. But in stage 2, one could add along with this oral or parenteral antibiotics. And stage 3, obviously, we need to take a vitreous tap, give intravitreal antibiotics and vitrectomy. There is a growing support for early vitrectomy in these eyes. there is a role for steroids in these eyes, as the collaborative blood-related study used corticosteroids both systemically and locally in both stage 3A and 3B and found favorable results. In terms of early vitrectomy, the data is a little divided as of now, though we tend to do early vitrectomy in these eyes. If you look at the data, there's no big difference between the initial intravitreal injection versus the early vitrectomy group. There are some studies which have shown that the vitrectomy group actually had a worse outcome. Anyway, these eyes definitely have persistence of infection. These eyes require retreatment. 35 to 40% of patients who had an initial intravitreal injections require vitrectomy, and nearly 20% of patients who had a vitrectomy often require a second vitrectomy. Some of these eyes may need the blood, better blood management here, scleral patch graft, or sometimes even excision of the blood. Removing these mini shunts and all that, whenever is a controversial thing. Some people believe that it's a reservoir for offending organisms. Visual outcomes, phlebitis usually minimally affects the visual function. But if you have blood-related endophthalmitis, the outcomes can be bad. Now, in one series, nearly 10% of eyes had no light perception, and nearly 8% of eyes had to be enucleated. Stage 3 and positive cultures were significant risk factors for poor outcomes. And with respect to IOP control, again, the collaborative study found that stage 3 was a poor prognostic factor for increased IOP. So to conclude, the incidence of blood-brain infection may be less these days, but blood leaks, mitomycin traps, young patients, and systemic disease like diabetes are predisposing factors. Early diagnosis is crucial. If you get to treat this patient at phlebitis stage, you could prevent blood-related endophthalmitis. Aggressive management is the rule. It's not like cataract. You cannot apply EVS guidelines to this. The organisms are different, and early vitrectomy concept seems to be safe and catching up. Thank you.
Thank you, Manoj. Manoj, one query. We glaucoma specialists would be the first one to see any sign of this. At what point should we get the VR specialist involved?
I think right at the time of phlebitis. Whenever you suspect phlebitis, I think you should send the patient to the VR surgeon for an opinion, because I think we would at least do an ultrasound, pick up vitreous opacities, and probably also kind of warn the patient that about the symptoms. And I think at that stage, if you can pick up patients at that stage and maybe overtreat a bit, I think we can prevent endophthalmitis.
This is one point where we have to be very aggressive, and we see a congested blood, we tend to add on steroids. We see a congested blood, make sure that the blood contents are not turbid. You may see small hypopyramid-like levels inside the blood. And early treatment. This particular patient that Manoj talked about, I saw her day before yesterday, or rather last week. 6 weeks, no treatment, nothing, not even topical lubricants, and she's happy 1.5 years down the line. And if we had missed out on a couple of days more, the story would have been different. Thank you, Manoj.
What is the first line of antibiotics that you use when you see phlebitis?
Yeah, normally it's fortified vancomycin and ceftazidime is what we generally advise.
Just like you would do in the
just like like in endophthalmitis.
Anybody with any further opinions need to discuss? We got about 10 minutes time. Ronnie, what's your take? You're from SN.
Yeah, so for us, the moment we see a phlebitis, our protocol is that the patient is seen twice a day, every day, either admitted or should come morning and evening, because if they're in stage 1 where the infection is restricted to the blood, they do very well with aggressive topical therapy. But the moment you have stage 2, some amount of anterior chamber involvement, and stage 3 is of course entirely your purview. So you have to be very, very aggressive, and this is again one situation where we give systemic antibiotics. We give oral systemic antibiotics to start with, and if necessary, IV antibiotics also. Just one thing that, with experience or with, unfortunately with experience, is that kids who have a URI early post-op, this is a major issue because that pneumococcus just goes up and you land up with very, very bad blood infections. So otherwise, hope and pray doesn't happen.
Yeah, I agree. Which systemic would you go for? And Saju, I just noticed you. Another VR surgeon, one more opinion. Which systemic would you go for when you're giving an oral in the early sitting?
So typically any broad spectrum will do. So typically in the early spectrum, we just give anything broad spectrum. We've anyway taken a culture and a swab, and then looking at that, but the next day we change if required.
We admitted all our blebitis. I mean, we didn't even consider outpatient follow-up. Two times a day is good enough because we see them only 2 times a day finally.
Yeah, so sometimes, I mean, if they can't come also, ensure that they come morning and evening. If they can't get admitted, so that's the reason we give them that. We don't give an option, but otherwise we make sure we see them twice.
The only thing that I want to add is topical, moxifloxacin may not be enough because now most of us may think that just putting them on frequent moxifloxacin may help. Because if we look at the spectrum, it's looks like most of these patients are kind of resistant to that. So it's always better that you change your antibiotic.
The same question I was about to ask is whether there is any role for intracameral moxifloxacin when it is limited to anterior chamber and bleb only. So it may not help, no? Moxifloxacin intracameral?
Intracameral, I'm not sure whether that's going to be of help, but at least in a stage 2, we would like to, we should add parenteral antibiotics. And I think moxifloxacin, if possible, should be avoided, is what I feel.
I also think that going in intracameral, you might just be the tipping point to send it to the posterior chamber. So it's probably better not to enter.
Stage 1 topical is enough. So, and once you reach stage 2, we want a depot there. So once you put something into the vitreous, it's there for 3-4 days. Once you put something in the anterior chamber, it's gone in about half an hour. So if you're putting anything into the eye, it's intravitreal. We got 2 more minutes. Manoj, I need a signature on this thing. Kiran, can you give the memento to Dr. Andrew?
Yeah, well, I want to ask a question. Yeah, please do. And that's about malignant glaucoma, because I think all of us have faced the situation where you have patients with malignant glaucoma and that persists, I mean, it recurs, it persists. You've done everything you can to control it. You've gone in, you've done your Chandler's procedure, you've done your, anterior vitrectomy, broken up the anterior vitreous face, but that patient still has persistent rise in intraocular pressure, and you find that only atropine, practically lifelong, is going to work for that patient. So what do you think is the mechanism of those kind of things, and is there any other approach that we can do to try and permanently solve that problem? How does that happen? That now even if the aqueous gets diverted, where is it going to collect and push things forward and things like that? Why is it happening?
I don't have any brilliant ideas. But what I feel is that if a patient is controlled on lifelong atropine, that means atropine is basically a kind of posteriorly rotating the ciliary body. So the anterior rotation that happened initially, that is where it starts, and I feel probably it's the initial hypotony that causes everything to move forward. That causes that first step because intraoperatively also this almost always happens moment you enter the chamber, right? Intraoperative it happens. So it's probably that early hypotony that causes that first rotation, and then things go on north from there. That is why probably when you have atropine and the patient is continued on atropine, the patient is okay. The moment you take it off, after the effect of atropine wears off again, it goes back. So I have no ideas beyond that.
The other thing is, the time that it has been shallow, probably some more synechia occurred. And so you have actually made it the next level of glaucoma from the closure point also. And any whichever way, atropine pulls back the iris, and that would help a little bit. And quite often, this situation of not being able to withdraw from atropine is when you medically manage the patient and you've actually not gone in and got rid of the vitreous part of it. Core vitrectomy probably should take care of it in case you have not hit the posterior vitreous phase.
No, I think there's one theory that has gone around that just removing the core vitreous is not enough, that you have to go and catch hold of the peripheral vitreous which is around the ciliary processes, and that should be done. And most of the vitrectomies that are done for malignant glaucoma are done by the glaucoma specialist, and we're certainly capable of removing, breaking the anterior vitreous phase and doing a bit of a core vitrectomy. But if you have to go and actually try and remove vitreous from where it is very, very close to or even surrounding the ciliary processes, you'd need an expert vitrectomy surgeon.
Yeah, so I agree, and that's absolutely the reason. I mean, you have to take out enough vitreous, you have to take out that you have to break the anterior hyaloid phase, you have to clean the vitreous in that area. So even for us, when we started doing the procedure 20, 30 years back, we have identified 2 or 3 retina surgeons who do the procedure. Because once you tell them that this is what you want done, it's not that we get huge numbers, so you have 2 people who do it with you consistently. And with that, with the proper vitrectomy done, I don't think we have had recurrences. It's a medically managed or half-baked vitrectomy where we've gone through the anterior segment where you have the recurrences.
A token of appreciation from KSOS. Kiran, please give a memento to Dr. Andrew. Thank you. I think we close on time. Thank you.
Thank you, sir. We resume at 2 p.m. sharp.